Physicians are right now not necessarily complaining, but they realize times are very different. Part of that is generational. I will say my generation is having the hardest time dealing with this because they were used to the old fee-for-service days, independence, the ability to change things the way they wanted, and they kind of ran the show. We've now reached a world where it is a team effort to take care of patients. There may be nurse practitioners in an office, other people doing other things to help with the patient care. And that's a little hard for them to accept because that wasn't the way they were taught, and that wasn't the way they practiced for many years. Another aspect is, quite frankly, is that reimbursement is going down. And many physicians are working harder, seeing more patients, and yet not making as much as they used to, or not making what they thought they would be making at this stage of their life. And that's frustrating too. On the other hand, we have the millennials who, are not used to anything different, so they're happy with, this type of care and the value-based equation and care coordination. However, their work hours are a little different. And where the older physicians may not be happy, they may still be used to working 70 hours a week and staying in the office late. And the younger generation now wants to go home at 5 o'clock and eat with their family, which is life balance and it's fine. But we have to figure out how we're going to do this, because clearly a physician who's working 70 or 80 hours a week represents two physicians working 40 hours a week. So we have to figure out how we're going to work with workforces and figure out, again, based on a generational basis. So they're not happy working in the old mode, and the older physicians aren't happy working in the new mode. So there is a little flux change, but I think most physicians are starting to accept this. I had the advantage of practicing in this new environment towards the end of my practice only because I was kind of used to that coordinated care in my role. Previous to where I am, I was the chief medical officer of the hospital I was at. I knew this was coming down the pike. I got my MBA over 20 years ago because I knew this stuff was coming down the pike. So I was kind of prepared for it. My office worked that way. We try to coordinate things, try to be accessible all the time. So it was less of a lift for me than it may be for other physicians, especially procedural-oriented physicians, which were very used to just doing what they wanted to do and nobody ever questioned it. The Two-Midnight Rule does have a financial impact, and it's very difficult for physicians to deal with. It's hard for them to think about whether somebody needs an admission or not based on the number of hours in the day or what time they come in, whether they come in at 11 o'clock at night or 1 o'clock in the morning, so that which side of the midnight they fall on. It's too artificial, and that's really not a good way to approach it. It's better to say, let's develop an innovative system so that people don't have to go to the emergency room to begin with. And that those that do, how can we make sure that we can send them home with the right resources? Because if we can send them home with the right resources, care for them for a short period of time, and then send them home with the right resources, they probably don't need to be in the hospital for a long period of time. The other insurers have not yet started with the Two-Midnight Rule. However, they clearly just use denials. Unlike Medicare, which doesn't really deny the days, those insurance companies just deny the care, and we often have to waste a lot of resources dealing with denials. Mm-hmm. And that is one of the, because it's expensive, both for the insurance company and for the hospitals. When there's a denial, the hospital feels it's justified, so they have to fight it. Insurance company wants to fight back, and it becomes everybody spending resources and money on something that really should have never happened. So I think that's why most of the major insurance companies are moving now for either pay for performance or for actual risk contracts, saying, you know what, you deal with it. We don't have to issue denials because you're going to decide if the care was appropriate or not, and then alter it that way. Now, that puts a lot of onus on the hospitals and physicians, and in many cases they're not really prepared because they don't have all the other resources involved. That is one of the reasons why we started our own insurance company, because if you have the premium dollars, it's much easier to have the resources, therefore, in place to provide that linkage of care that you need. I like being in an administrative role. I miss my patients. Thankfully, some of them still call me back and ask for advice, and that's very nice. I do teaching at the medical school. I do attending rounds in the hospital, so I keep my hands in it. I know what it's like to walk on the floors and see patients and examine patients, so that's good. What I like about my administrative role and the increasing responsibilities I've had over the years is the fact that now I have the opportunity to hopefully improve the quality of care for a larger population. When I was in my office by myself, I always said it was one at a time. Now I have the opportunity with our large catchment area, if hopefully we do the right things, we improve a lot of care for a lot of people. The best example I give is, and I did not lead this myself, but it's under in the health system, was our work in sepsis. And we just won a major award for our work in sepsis and reducing mortality. And what it translates into is, compared to 4 or 5 years ago, there are 100 people every month in our health system who are discharged and go home to their families that would have died 5 years ago from sepsis. And the opportunity to do things like that is really the nice thing about the administrative role.